Good afternoon, everyone. This is Diana Arias with the Community Technical Assistance Center, and I would like to welcome you to today's webinar, Cultivating Inclusive DBT Treatment for Sexual Minority and Gender Expansive Youth and Their Families. This webinar will focus on the importance of creating inclusive clinical environments. Before we get started, I want to take a moment to orient everyone to the WebEx system so you know how to participate in today's event. Please note that upon joining the webinar, you have been placed on mute to avoid any background noises that may distract others from listening to the presentation. If you come across any technical issues during today's event, please chat to the host who will be able to assist you. We will be utilizing the poll feature during today's webinar. When the slide appears in the presentation, a question will appear on the right-hand side of your screen, and I strongly encourage you to participate by selecting the option that best represents your answer. Also, in order to ensure that we are able to answer as many questions as time permits, we are requesting that you send in your questions at any point during the webinar, and we will address them during the Q&A portion. You can submit questions by utilizing the chat box feature, which is located on the bottom on the bottom of your screen. If it's not visible, click on the dialog bubble, and it should appear. When submitting your questions, please send this to the host only so as to not distract our presenter. I am very excited to have with us Ryan Lindsay, social worker committed to addressing LGBTQ issues. Thank you all for joining us today, and I'm now going to turn it over to Ryan to get us started.
Welcome, everyone. My name is Ryan Lindsay. I'm the Assistant Dean for Social Work at the Brown School at Washington University. I am a practicing DBT clinician and a board-certified, national certified DBT clinician. I've been practicing DBT for almost 20 years, and it's a treatment that is very dear to my heart because it's designed to help people that experience excruciating pain and helping them to find lives that are worth it. That's been a part of my mission in life is to try to eradicate misery, and DBT is one of the options for that. So before we get started, I just want to do a few shout-outs and thank yous to the Community Technical Assistance Center of New York for inviting me and prioritizing this as a webinar. Thank each of you, all 97 of you that have shown up today to learn a little bit more about cultivating inclusive DBT treatments for sexual minority and gender expansive youth. This is a really important intersection given the chronic invalidation that many of our youth experience. And so I'm excited to share some of the experiences that I've had and expertise around this so that we can help disseminate and enhance the capacity for programs to be more inclusive and affirming. So I'm excited to kind of walk you through this journey. So I'm going to orient you to what we're going to be doing today. So I'm going to cover some definitions around defining sexuality and gender affirmative care. We're going to explore the intersectionality as it relates to multiple identities. We're going to link DBT as an inclusive treatment for treating chronic invalidation. And then we're going to explore specific organizational and provider level strategies or interventions to increase affirmative care. So I'm excited to share this with you all. So on your screen right now is a poll question. Part of what I want to be able to know is to get a sense of what is our starting point for people's DBT knowledge. So if you could select the item on what type of DBT training you have received, so that I have a better sense of who's in our audience of the 104 now of you that are here.
Hi everyone. I am the technical host of it, and our polling feature is actually frozen right now. So if you could actually just message in your response to all panelists, so Ryan and the host can see your responses, that'd be great. Thank you, and sorry about that.
From what I'm seeing, we have a pretty large variance of people who have had a lot of trainings to people who haven't had any training. So what I want to do is level set a little bit. We only have 45 minutes today to talk about some very, very complicated topics. So this is really designed to pique your interest, give you some very specific ideas around how to think about both of these items, but frankly to be able to apply across any type of care setting when we're thinking about affirmative care. All right, so I'm going to move on to let's level set and give and orient you to the definition of what I'm thinking about when I'm talking about sexuality and gender affirming care. So I think about sexuality and gender affirming care as any health care that is aware, knowledgeable, and responsive to the unique needs of sexual minority and gender expansive people. This includes knowledge, skills, and competencies of the healthcare provider as it relates to each of these concepts, organizational priorities that reflect the needs of this population. So there's an intentionality behind the priorities that are set within the organization. And then also the emphasis on safety, security, and confidentiality, knowing the sensitive nature and the protection that is necessary when working with any marginalized populations and in the context of potential danger, as well as the emphasis on creating accepting, welcoming, and representative environments. And so when I'm going to talk about what is affirming care, this is the definition that I am going to go off of through this presentation. I'm also going to do some level setting in terms of what are the differences between gender identity, gender expression, biological sex, sexual orientation, and just so that we understand what the differences between some of these terms mean. Gender identity is really about how one thinks about themselves in relationship to their internal experiences and their external experience. One's gender identity is how one thinks about and experiences themselves in relationship to gender. Gender expression is how one presents themselves to the world, how a person shows up in relationship to traditional gender roles, but also those gender roles that are embedded in cultural norms around gender. Sexual orientation is how and to whom one is physically, spiritually, and emotionally attracted to. And I also want to separate out, there's a difference between what gender identity, expression, sexual orientation, and a person's behavior. People can engage in a range of sexual behavior that may include opposite sex behavior, same gender behavior, or a range of gender identities, but may not feel spiritually or emotionally attracted to one or more genders. So there are many people in this world that engage in behaviors that don't identify their sexual orientation in any particular way or their gender identity. That's important. I'm going to talk a little bit about some terms that we are in response to gender. For the purposes of our time today, I'm going to use the term gender expansive youth. There are a range of individuals who identify as transgender, or gender nonconforming, or TGNC. There are a range of identities and words that people have adopted to represent their true identities. But for the purposes of today's talk, I'm going to refer to the range of identities under this umbrella term of gender expansive. And I realize that for some, this terminology may be insufficient. And I just wanted to recognize that. And I had decided to use HRC's term of gender expansive youth to have the broadest application. So I want to define, individuals who experience and talk a little bit more about what is transgender, the differences between cisgender, non-binary, gender fluid, and gender queer. Just those are additional terminology that we often see out there. An individual who identifies as transgender typically refers to someone who does not identify with the gender they were assigned at birth. As opposed to cisgendered individuals refers to someone who does identify with the gender they were assigned at birth. So I was assigned male at birth. I am a cisgendered male, gay male. So that is what I use he, him, his pronouns. Individuals who identify as non-binary, this refers to someone who does not identify as exclusively male or female or with no gender. Gender fluid refers to somebody whose gender identity changes over time from one end of the spectrum to the other. And genderqueer refers to someone who identifies on the spectrum between male and female. The most important piece to understand about terminology and pronouns is simply to ask and to respect and mirror the language in which somebody engages. So that's something in terms of our level setting for today. Also embedded in all of these slides are links to a whole host of resources. So I encourage you to log back in and collect and get the slides so that you can get access to the sources of a lot of this information. When we're talking about sexuality, first off, I want to talk that sexuality includes behavior, physical and sexual attraction, emotional connectedness, and spiritual connectedness. Sexual orientation is distinct from gender identity and gender expression. We need to dismantle our bias towards heteronormativity or the assumption of opposite gender attraction. That's a point of the premise of today's talk is really about how do we dismantle this bias and recognize that gender doesn't equate to sexuality, as the full range of sexual orientations are experienced by the full range of gender. And so on here, these are some definitions from the Human Rights Campaign, their glossary that they have on their website that looks across the range of sexual identity. I want to talk a little bit about the importance of coming out. First, coming out is not a process that all people have to experience. It's a unique experience that people who are sexual minority or identify as gender expansive must engage in, whether they desire to or not, because of the default systems within in our world of assuming heterosexuality and a gender binary. And there's particular experiences that lead to a sense of chronic invalidation when one's identity is not seen in the world, or when someone has to navigate the world in a continuous process of coming out. Coming out is not, I came out of the closet on this date. Every single day, there's an experience of coming out. Every new person, every new context, every new experience that somebody engages in, there's a level of coming out. And so because it's the default to think binary and to think in a heterosexual type of way. So I think that's something important when we think about defining what this process looks like. Really, it's about identity formation, and then it's experienced as beginning self-awareness, and then moving into acting and then openly disclosing to others, and how that shows up throughout the course of one's life. The counter to the important factors to kind of recognize is that this is unique for every individual. It's very culturally embedded. There are different cultural, religious, and community expectations, familial expectations, and peer group expectations that influence this process and this trajectory, but also can lead to some problems in terms of the process of coping and the process of developing, a strong sense of true identity, but also in a healthy and enhanced mental health way. So those are some level setting, recognizing that I cannot do that topic justice. That's probably an entire week long we can have conversations around. So why am I going to talk about dialectical behavior therapy? The purpose of talking about DBT is that, and why it's particularly relevant for sexual minority and our gender expansive youth, is because the existence of emotion dysregulation comes from the chronic experience of invalidation. And I'll talk a little bit more about how that shows up. But DBT is a CBT treatment that integrates acceptance and change strategies in the service of enhancing problem solving, but emotionally focused problem solving. And when a person navigates the world in the context of chronic invalidation, it erodes a person's sense of self. It also erodes a person's capacity to learn how to problem solve. And some people have the internal capacity and resources combined with an environment that helps to support this trajectory towards healthy development, and many other people do not have access to either internal or external resources to help on that. DBT is a very comprehensive treatment that is really designed to help people develop the skills and capacity to regulate their behaviors, to regulate their thinking, and to regulate their emotions in the service of their long-term goals, or in the service of finding their true self. And so DBT has always been a treatment that is an integrated treatment. It has Eastern and Western philosophies that drive its underlying theoretical orientation, but also the emphasis on skill and empowerment and autonomy and choice is critically important for any marginalized population to take back control over factors that often feel out of their control. So DBT is a particularly good fit. DBT is also designed, the overarching goal of DBT is to build a life worth living. DBT recognizes that specific problems in relating to oneself or to their world, and combining that with specific skills deficits prevents people from feeling that the world is actually worth living in. In order to build this life worth living, we must learn how to navigate and to regulate. So we've got to decrease some very important problematic behaviors and experiences in the service of building long-term goals, or striving towards achieving long-term goals. So in DBT, a comprehensive DBT is only a comprehensive DBT program, has individual DBT therapy, a DBT skills training group as a part of that, 24/7 access to skills coaching, and a DBT consultation team for the providers. This is the gold standard for DBT, a comprehensive DBT program, and full DBT programs are most effective for those that are experiencing severe or suicidal behavior, so the range of suicidal behaviors, but also severe and problematic quality of life interfering behaviors. So there's a range of options for people out there for treatment. DBT is very skills focused, but it's in the service of understanding one's own emotional experience. So I think about DBT as emotionally focused and focused on problem solving through enhancing our capacity to regulate our own emotions, to be aware of our experiences, and to act interpersonally in ways that achieve long-term goals. So what is the problem we are solving? So in DBT, it's a behavioral-based treatment, so we're always looking at what problem is being solved and what is the function of a behavior. And so for the purposes of today, the problem that we're trying to solve in DBT programs is the presence of heteronormative and binary gender role bias in our programs. And so what we are shooting for is that all DBT programs provide sexuality and gender affirming care. And this should be default in all healthcare. Unfortunately, that is not the case, but especially in our DBT programs, because we see a very high rate of individuals experiencing suicidal behavior, self-injurious behavior, and other high-risk or problematic behaviors as a result, sometimes solely from the chronic invalidation and environments that are creating pathways to dysregulation. And so our DBT programs generally are seeing a high rate of individuals who are quite fluid in a lot of ways. And so we have to be affirmative, and we have to be really intentional about how we are setting up our programs to provide sexuality and gender affirming care. So what are some of the factors that interfere with this goal? And so I've broken this down and very oversimplistically broken this down, but to look at some clear biases that exist in our systems. And when I think about what is bias and defining that, bias is simply the tendency to experience, perceive, interpret, or draw conclusions through a particular lens without consideration of what is being left out. And if you know anything about dialectical behavior therapy, that is dialectics in action. And so when we think about this, we have systemic biases that include our educational biases, in the training, our accrediting body biases, and then all of the policies and other social structures that have created bias and exclusion for our sexual minority and gender expansive youth. For the purposes of today's mini workshop, I'm going to focus on two. Those are really huge topics, and I want to focus on organizational bias and provider bias today, because that is more that we have more tangible solutions that we can immediately create sexuality and gender affirming care by addressing these levels of bias. So at the organizational level, you have a leadership bias. So bias means a tendency to experience, perceive, or interpret or draw conclusions in a particular way. And if you are not a member of a sexual minority or experience yourself as cisgender, there's a lot of bias that comes from that privilege to not have to prioritize. And so we need to address leadership bias. There's employment bias. Who are we hiring within our organizations to serve the people we are serving? Our policies are biased, and the environment, the physical environment of a clinic has bias around that. And so we have to be very intentional about what are the interventions or strategies to cultivate affirming organizations. Combined with that, you have provider bias. And so that is a personal provider bias. So that is what is a person's historical understanding and narratives and perceptions and levels of privilege around gender and sexuality. And then also, frankly, our programs that train providers and who is doing the training and how much of that training is focused on affirmative care and knowledgeable about affirmative care. And so so for the rest of today, what we're going to talk about is organizational bias and interventions as well as provider bias. All right, so I'm going to take a drink here. So when I'm thinking about what do we need to increase in terms to get us closer to affirmative care? So we have organizational behaviors. And so first we have to have sexuality and gender affirming care prioritized by leadership. We need to focus on policies and practices that are intentionally inclusive and affirming. We have to address employment, hiring, and human resource policies and practices that are also intentionally inclusive and affirming. And we have to focus on our environment, the clinic environment being representative of minority, a range of minority populations, but specifically sexual minority and gender expansive people. And then we have to have a clear expectation to prioritize staff training that is inclusive across the board, not just providers, but every person that works within a clinic to have staff training focused around those issues. At the provider level, we need to improve self-awareness of provider privilege and default conceptualizations and their own bias. We need to integrate minority stress into our case conceptualization, and I'll get to that in a minute. We have to integrate a default lens of intersectionality into case conceptualization, understanding that multiple factors influence an identity, and this intersection compounds. This intersectional lens is necessary for us to truly understand and to see people as they are, and to, more importantly, help them build lives that are worth living. We also need to think about how minority stress and intersectionality fit into our behavioral assessments and solution analyses. And when we're talking about training and helping people learn interpersonal effectiveness skills, we as providers and organizations need to build our own repertoire around how we repair when we make mistakes. We are all fallible. DBT makes this assumption. So we will assume that we will make mistakes. We just need to know how to own them and respond to them and repair them. And also provider behaviors around shame. When we make mistakes, we need to prevent a shame spiral that that puts the burden on the environment to solve the provider's shame. And so we need to have some additional training around those pieces. All right, so let's talk about organizational level intervention. So at the organizational level, I think it's important that the organization engage in assessment of inclusive and affirming policies and practices. And so this is leadership saying, we care about this, we care about people being seen, and we're going to prioritize an evaluative process in order to ensure that we are intentionally embedding strategies and mechanisms that show we care. And so this includes leadership explicitly communicating inclusive and affirming culture within mission, values, or leadership principles, that it's clear, it's written, that organizations, when hiring people in leadership positions, but also across the board, are screening for inclusive and affirming knowledge, beliefs, and practices, and that employee experiences of inclusion are actually assessed. So there's a process of getting feedback from employees at the organization of how inclusive the environment is and how affirmative they believe the environment is, but also getting feedback from client level, feedback around inclusion and experiences of affirmative care. And we are often engaged in efforts to create a culture in a particular way, but it may not be landing that way. And our employee and our client feedback is critically important to help us level set when we think we're doing a really, really good job, and maybe there's something that's preventing it from landing in a way that we are hoping it to be. Additionally, the organizational hiring practices have to include diversity and inclusion. There needs to be intentional outreach and partnership and development within local fields so that we can attract people of diversity in general. So diversity, inclusion, and equity are a critical part of this, and that specifically your employment non-discrimination policies include both the terms sexual orientation and gender identity, as well as employee benefits, including medical coverage supports a range of identity. Additional organizational level interventions include policies and procedures that are sexuality and gender affirming, meaning paperwork includes options to select sexual orientation and gender identity, and a range of them, and paperwork also provides an option to not disclose. As someone who is a founder of a mental health clinic, and we do bill insurance, there are many of our systems require, for medical billing purposes, to collect gender. So the way that we have this identified on any of our paperwork is gender assigned at birth, and if that is a requirement. I've been actively working towards determining the purpose of gender, and even in our EMR system, in order to open a case, you must assign a gender. It doesn't allow you not to assign a gender. And so we've been working with our EMR system to be able to develop a workaround around it. We also need to look at psychosocial assessments that prioritize the intersectional lens. Why this is at an organizational level? Because this is about people in the stakeholders that are at the supervisory and management and director level also is showing up in a way that represents an intersectional lens and understanding of minority stress factors. And then also client non-discrimination policy includes terms, the terms sexual orientation and gender identity. Finally, the built environment needs to represent multiple identities and the intersections of these multiple identities. So in the pictures and the brochures and the types of magazines, having all gender bathrooms or policies that allow clients to use the bathroom aligned with gender are really important to be able to build a built environment that is also affirming. All right. Provider level interventions. So at the foundational level, training in LGBTQ+ affirmative care needs to at least at minimum include definitions, key issues, and intersectionality of identities around specific health concerns, disparities, and risks, behavioral health practice and interviewing and asking questions related to gender and sexuality-related issues, specifically targeting issues of bias, repairing mistakes, and also looking at privilege in this context, self-awareness in context. And then training on what is minority stress and how stress arising from social stigmatization, stress arising from social stigmatization amplifies a person's sense of chronic invalidation. When we're thinking about an intersectional lens, so the Institute of Medicine in 2011 published The Health of Lesbian, Gay, Bisexual, and Transgender People, and inside this report, they identified these four elements that we need to, and frameworks that we have to be thinking about when engaging in assessment and also in the care that we're providing. First, that we have to understand life force, that different people have different needs at different stages of life, that social ecology matters, meaning social contexts do influence health outcomes, and we have to be aware of how those factors intersect, that minority stress or chronic stress arising from social stigma impacts both the internal and external processes of people, and intersectionality. Recognizes social, ethnic, religious, economic, culture, and other factors influence the lived experiences of sexual minority and gender expansive people. That these four elements should be embedded inside your case conceptualization, should be embedded inside psychosocial assessment, but also are critical factors to help us understand so that we are not pathologizing the effects of an environment. And that's a really important piece. People need to understand that chronic stress and invalidation do result in potentially in problematic coping, but it is not pathological in and of itself. It's actually oftentimes this is a normative response. This is a normative or reasonable response given the environment and given the internal resources of the individual. And so our treatments need to be really focused on understanding that factors externally can reinforce and amplify existing experiences and make any person in that context, even with the most effective coping skills, struggle. And so that if you have the right combination, people's mental health is impacted by it. So when we're thinking about provider level interventions and intersectionality, I'm gonna talk a little bit more about this because I think this is what we don't do well in a lot of spaces. And what the demand comes from our sexual minority and our gender expansive youth. There's a demand coming saying we must be understood in context of our intersection. And that in the context of this intersectionality, there are pieces that lead to oppression. And this intersectional oppression that includes racism and discrimination, cultural appropriation, institutional oppression, transphobia, homophobia, ableism, and classism, all of these factors come together in an individual person, combine and amplify. And this chronic experience can lead people, if they have a biological vulnerability, towards experiencing mental health conditions, or a lack of an environment that's able to shift the trajectory, that these compounding factors are really important to understand and disentangle, and that we have to understand that gender expansive youth of color face additional and different and unique stress and adverse effects of this to their health and well-being as a result of both bias, the intersectional bias, and discrimination on a daily basis than non-youth of color. And I think it's important that we're recognizing the compounding factors and how hard it is for people to feel like they can move forward in these contexts. And also recognize that there is a way to move forward. And that's why DBT was developed, is to look at intersectionality and multiple diagnoses and competing factors and environments that make it next to impossible to want to build a life that's worth living, to build a life worth living. Some top health risks that are directly linked to this compounding intersectionality. And specific to DBT is the experience of depression, suicide, and other harmful behaviors that amplify or function to regulate emotional experience. All right, so I'm aware of time, so we've got a couple more pieces to get through. So in general, DBT actually has embedded in it a philosophy that is consistent with sexuality and gender affirming care. Its dialectical philosophy is grounded in inclusive and affirmative perspectives. The biosocial theory includes the transactional nature between one's biological vulnerabilities and environments and how these transact with each other and amplify. The focus on problem solving is really about how do we empower a person to build their own sense of mastery and autonomy in this world, but also recognizing there's limitations. DBT's focus on self-regulation and emotion regulation is particularly useful in this context, given the biosocial theory says that the behaviors and emotion dysregulation is the direct result of chronic invalidation in one's environment, pervasive invalidation. And we can work with families to develop this wide range of strategies of walking the middle path that balance both acceptance and change in the service of enhancing family relationships. The data is very, very clear. The more protective and affirmative a family is, this is our key ingredient in terms of shifting trajectories for youth and improving health and mental health outcomes. So in DBT, it's based on the biosocial theory. I could talk an entire day about the biosocial theory, but basically the idea around this is that one's emotional vulnerability, so either their high sensitivity to emotional stimuli, high reactivity, or slow return to baseline, these are biologically programmed. We all have a variance of our responsivity in terms of our emotional vulnerability. When this interacts with an environment that rejects, oversimplifies, or punishes expressions of internal experiences, create problematic outcomes. Because what happens is high emotionality is met with control from the environment, and that control oversimplifies a person's biological predisposition to experiencing the world and emotional stimuli in particular ways. And so when these two things transact with each other over time, where an environment is unable to figure out how or to be supportive or how to teach coping and soothing in these contexts, or a person's emotional vulnerability is so high that environmental interventions are actually difficult to shift trajectory, the outcome is a pattern of behavior that makes it difficult for youth and young adults and into adulthood to organize their behavior in service of their long-term goals. And so that's a really oversimplified statement, but when we apply this specifically to sexual minority and gender expansive youth, we find ourselves in context of understanding that there is a tremendous amount of chronic invalidation that exists. And that pain of not being seen by their loved ones, their family members, and their peers, their community, represented in media in ways that accurately represent their experiences. This chronic invalidation leads to a significant amount of clinical distress. And so there's a whole host of experiences that people are having on a daily basis that many people don't if you are part of a dominant or non-marginalized community. So these pieces are critically important also to understand that we are trying to regulate possibly We're trying to help people learn how to regulate in a context that's chronically invalidating, which is a really tricky thing because they shouldn't have to feel invalidation. And at the same time, the world continues to invalidate. And this is one of the problems where we sit with in the dialectical dilemma that often we are working with when working with these youth. And so, again, the amount of safety issues that many of our, particularly our gender expansive youth, are experiencing, particularly in school bathrooms, direct assaults on rights in these contexts, and physical and victimization within these contexts is rampant in this population. And we have to be really aware of this. And we also have to advocate significantly if we're working with youth in these contexts with their schools, because youth rarely have the power to be able to shift a large bureaucracy. And so we need advocacy, and we need to give youth skills in advocating for themselves. But we also need to be advocating on top, in addition with them, because it's often not sufficient enough to shift people in power's perspective. And I want to talk about a concept of traumatic invalidation. So Marshall Lenehan talks about traumatic invalidation as extreme or repetitive invalidation of individuals' significant private experiences, characteristics identified as important aspects of themselves, or reactions to themselves or the world. This is often at the hands of an important caregiver or loved one. This includes accumulated misgendering, the range of microaggressions from microassaults, insults to invalidation, and the impact on the emotional vulnerability of many of these youth. And when we think about traumatic invalidation, and I think about the people I've worked with, particularly my adult age clients, they've experienced a whole host of physical, sexual assaults in their lifetime. And the things that stick with them most often, those are traumatic and horrible, but are actually some of the traumatic invalidating experiences they've had that haven't included physical or sexual assault. And this goes to the core of the sense of who these individuals are and the people who they look to care for them the most, failing to show up in a way that means something really important to them. And so I want traumatic invalidation to be at the forefront of thinking when we're working in context of any marginalized communities, particularly ones that experience chronic invalidation. Because traumatic invalidation has long ripple effects and influences how people can make sense of themselves in relationship to the world. It impacts their relationships later. It impacts their sense of self and also sense of shame around the context. So the role of clinical distress for sexual minority and gender expansive youth. I think I've explained a lot of it. And so I want the specific elements of how it connects to DBT is within the context of emotion dysregulation and behavioral dysregulation. So thinking about a dialectical framework to inform our conceptualization and treatment of this clinical distress, we have to be thinking about how external factors contribute, amplify, and reinforce both behavioral and emotion dysregulation. And so I'm going to give you an example of how this works in a quick model. The biosocial theory talks about emotional vulnerability plus a lack of internal coping resources or the existence of skills in transacting with an environment over time. So when we think about how this doesn't just happen once. Invalidation happens on a daily basis for people, but when it's chronically invalidating to the sense of self of a person, this dramatically increases a person's reliance on the external to regulate them. And so people fail to learn effective emotional regulation, stress tolerance, and interpersonal skills, and it reinforces ineffective emotional regulation. Because what happens is environments tend to respond to problematic responses, because especially when it comes to suicide and self-injury and really problematic behaviors, because the environment only responds in those contexts. So a large amount of what we are working on is trying to teach people to self-validate, to be able to recognize and label their own emotions, but also solve problems in ways that are clear, and to undo the reinforcing factors that have contributed to the way in which they solve problems now. And so an example is my client, Sean. Sean, when I was working with Sean uses they, them pronouns and identifies as non-binary. When Sean came to work with me after multiple suicide attempts and engaging in self-injury and substance use on a daily basis and school refusal, this was a person who had a very severe sensitivity to interpersonal rejection. And it makes a lot of sense. Most humans want to be seen, and they want to connect with others. We're made for connection. We're literally made for this, genetically made to connect with people. And the chronic invalidation that Sean has felt throughout their lives really led to them not being able to see a future, and looking at ways of regulating emotions in the context of suicide, as that was the way to solve feelings of shame, feelings of sadness, and feelings of hopelessness. Their emotional vulnerability has always been, when Mother described early on, that Sean always struggled to soothe as an infant, had severe separation anxiety when they were a small child, intense tantrums that took hours to soothe. Tantrums are normal, taking hours to soothe and having the frequency in which they were occurring, that's not a typical developmental trajectory. And an environment that really failed to be able to teach Sean how to regulate emotions, how to self-regulate behavior, how to interact with others, because a big part of Sean's upbringing was figuring out their gender and how their gender in context was either being validated, invalidated, accepted, unaccepted, or attacked or not attacked. And so the result of these transactions led to pretty problematic coping and vacillations between having very large emotions and doing everything they possibly can to not feel. And by the time Sean ended up in care with me, self-injury was common, a frequent daily activity. Sean had attempted suicide 5 times by the time they ended up in treatment with me, and at the time of starting, was using marijuana on a daily basis. And so when we think about the skills deficits from DBT's perspective, it's really looking at how do we help Sean develop the distress tolerance skills that are necessary to get through this world, the emotion regulation skills to get through this world, and the interpersonal effectiveness skills to get through this world. Sean wanted to live. Sean wanted to build a life that was worth living, and a life that they could see themselves being validated. And sometimes that's learning how to navigate our world, and also accepting the fact that invalidation is actually a functionally part of our lives. And so Sean's case here helps to embed how do we then think about this from an affirmative care space. And I recognize that we've got probably 10 minutes left, and so I'm going to move through some of these specific elements that help cultivate affirming individual therapy. First off is we have to be representative. So take the Safe Zone training, it's fairly good. Have pride flags that represent various genders and sexualities. Why there's more than just the rainbow flag. On badges, you should have names and pronouns for all therapists. introducing yourself when you meet new clients by introducing your name and your pronouns. Listening to the way that people describe themselves. It is not always apparent, and you can't just assume that a person who may have their gender expression as male that they utilize male pronouns. That's important to understand. Listening and communicating that as a clinic and as an organization, you understand that sexuality and gender identity are spectrums and fluid at times, and that non-binary and heteronormative process assumptions are out of date. We want to affirm the person's true sense of self and always focusing on what our standards of confidentiality are within this context. The Fenway Guide to LGBT Health in their second edition has some pretty decent questions that you can explore, integrate into your assessment process to specifically get at gender minority stress and sexual and gender minority stress in a clinical encounter. I highly recommend this as a resource. It's a very, very filled with a wealth of information, so I encourage you to access that. In skills training groups, we want to offer nameplates with options to include gender, and that when you introduce yourself in the skills training group, you introduce yourself with your name and your pronouns. You do have the opportunity, especially in these contexts, people can choose to not self-identify, and that we should not require that. And if somebody is misgendered, then the group facilitators really need to remind the group that if this happens, that we call it out. We call attention to that. We don't make a big deal around that, but that we accept the concepts of fallibility in this context, and also we want to protect our youth who have disclosed the use of their pronouns. And so this is, and it's also a good reminder for everybody to take out nameplates. So I use that in the classroom all the time as an instructor and an educator, and I also do it in skills training. On our teams, similar outcomes. We want to incorporate gender and sexuality minority youth experiences into DBT consultations. We want to mindfully correct any misgendering that occurs when speaking about any client. So in DBT, we have a bell. We ring this bell in any context in which either judgments arise or we also use that in the event that we accidentally misgender one of our clients. We want to make repairs as necessary, and that we ensure sexual and gender minority issues and topics are part of our professional development goals. So I know that this was a whole host of strategies and information. I talked a lot. I want to give an opportunity for some questions at this point.
Great. Thank you for that presentation, Ryan. We are going to be going to the questions that were submitted during today's presentation. And as a reminder, you can certainly still submit questions through the chat box. So our first question is, Ryan, I know you mentioned this earlier on in terms of including gender on paperwork, but one of our attendees was asking, why is it specifically necessary to identify gender on paper? What real difference does it make?
Yeah. I think there's a couple different items that it's related to that. I think that gender does matter. A person's gender identity does matter to them. We don't want to erase gender because gender does have factors. Why gender is required is a different question. And most insurance companies and most medical facilities, hospitals, they use that as identifiers. And I question the way in which we use that. I have yet to figure out the policy, how to change that policy with insurance providers that I have engaged with, and I have yet to figure out why EMR systems require that to even open a case. So I'm advocating for that. I do think it's an important question because people's genders do matter. But it also matters that people can have the opportunity to either disclose or not disclose that. There's implications to the answers on that.
Great, thank you. So I know you talked about misgendering either in group sessions or as well as, within an organization, but there's a question here. I have a client who is misgendered by family during arguments and otherwise act supportive. How is this best addressed within the family context?
Yeah, I think it depends if I was working with this family and this occurred in the context of that. I would have individual conversations with the family members about how hurtful that is, but I would also, DBT is all about equipping the youth to be able to articulate their needs and wants. And it would be really important and empowering to teach and help the youth to be able to articulate to their family members how hurtful it is when especially inside arguments, that misgendering occurs. Recognizing that when people are heated, they go to their defaults, and it also can land very intentional and extra hurtful in these contexts. And so I would work with both family members to recognize they may actually not know that they're defaulting. Gender is very encoded in our language and our understanding and categorizing people. And so to undo decades of way of conceptualizing is a very hard thing, and it requires great attention to do that. And when people are dysregulated in any context, we default to emotionally driven language, and so we are often not quite as intentional. So I work with both ends of that.
Great, thank you. I'd like to squeeze in one more question, Ryan, so maybe just in a minute or less in terms of this response. But have you found emotional dysregulation to be more intense with LGBTQ people of color?
I don't find it more intense. What I find is that it's layered. And so to unpack and understand a person's triggers that bring emotion dysregulation, not necessarily the intensity of it, but it's to better understand it to get to solutions. And I actually find that being able to unpack the layers and to be able to say what is actually going on here in your interpretation of this experience, and then, okay, how do we address each one of these? So that would be my response.
Great, thank you. I do recognize that we started a little bit late, and I am cognizant of time. So to all our audience members, we do have Ryan's email up. If there's any questions that you want to forward to us, and we can certainly forward to you. Certainly, please feel free to do that. I do want to highlight, Ryan, again, thank you very much for this presentation. Ryan has also included several lists of resources that you can have access to from the downloadable PDF file, which will be available within the next 3 to 4 business days. But there is a lot here around language use per se, labels, and I think just overall resources that would be helpful for those working with LGBTQ youth and families, but overall within the community of LGBTQ. Again, I want to thank all of you for joining us today. You will be receiving a short survey after this presentation. We certainly appreciate your feedback. And I do want to point out that we do have additional upcoming CTEC events. Please visit our website for additional information. But again, we do want to thank Ryan Lindsay and all of our attendees for joining us today. On behalf of CTEC and our presenter, thank you for joining us, and have a great rest of the day.